All right, I'll give it a couple minutes here. Right. I'll go ahead and get started. First off, thanks for all y'all for coming, and I found this article to be quite timely for a couple of cases that we've had most recently with some PLNs and cats. I find them to be really challenging cases, and ultimately, I feel like we do what we can and get the best out of them, but I do struggle with them, and so I think that this paper was nice and timely for some of the cases that we've had recently. So I'll be presenting the clinical findings, prognostic factors, and outcome of protein-losing nephropathy in cats. It's a retrospective study out of the Koret University in Jerusalem. So first off, I wanted to kind of present a brief summary on a case that we've had that is no longer with us, but this cat was Luna. She was a 3-year-old female spayed domestic short hair that originally presented to us as a transfer from another specialty hospital. She had some lethargy and appetence and weight loss that was really progressive over a couple of weeks. She ended up presenting with a grade 4 AKI. Her creatinine was at 7.3. She was not hypoalbuminemic at 3.1. She had a BUN of 102. Her UPC on presentation was at 3.2. Her abdominal ultrasound showed severe hyperechoic renal cortices, and we ended up doing an FNA of the kidney, which just showed mild mixed inflammation, no evidence of lymphoma or neoplasia. We ended up submitting a urine SDS page, which showed a high molecular weight band loss and some tubular loss as well. She had some infectious disease testing. She did test positive on an IFA for Bartonella and all 3 species. She did have a GI panel that was performed as well, and her cobalamin was greater than 1,000. So just to kind of set the stage there. I feel like these are kind of the common workups for these PLN cats. And so traditionally cats commonly develop more chronic tubular interstitial disease, and which leads to fibrosis. Usually the underlying etiology for chronic interstitial nephritis is not well understood. And typically there have been some studies that have shown a prevalence ranging up to 30% in cats that are more geriatric. And so ultimately, this is going to be the predominant form of kidney disease in cats. It's obviously when we are set up in a situation where these cats don't necessarily play the role and have something else going on where PLN is going to be the biggest concern. The histopathologic features typically are going to be kind of expansion of the extracellular matrix in the tubular interstitial space. The renal vasculature is obviously abnormal as well, and there is some atrophy. We can also see some mononuclear cell or inflammatory cell infiltration in the tubular interstitial space, but typically the glomeruli are well preserved, and this is more tubular interstitial disease. In the PLN cases, PLN caused by primary glomerular disease, whether that is ICGN based or non-ICGN, it is not a common presentation. The lesions in cats that have been biopsied, both antemortem and even postmortem, the most common finding is going to be membranous glomerular nephritis. The second most common is going to be a membranoproliferative glomerular nephritis, and so that has been documented in two recent papers, one out of the Ohio State, and then the other one, oh, I forget, I think it's might be Italy. The cause of PLN, trying to determine the underlying etiology can be a little bit tricky. There is a primary or idiopathic form. There's also immune complex deposition as a result of chronic antigenic stimulation, whether there's going to be chronic inflammation in these patients, some neoplastic process, or an infectious etiology as well. The non-ICGN cats, really, we worry about amyloid or less commonly segmental sclerosis. And so I still think that amyloid needs to be a top differential in some of these PLN cats as well. And we'll kind of get into that a little bit later on. So in practice, unfortunately, renal biopsy is not a common diagnostic performed in these cats, and we are typically left with kind of a tentative diagnosis based off of clinical presentation and laboratory findings. In one study, in their cohort, there we go, my bad. The UPC had a cutoff of 3.8, which was distinguishing more of an ICGN phenotype versus chronic interstitial nephritis. And, I think that typically in cats, when they do come in with an elevated UPC, the question is how much of this is primary glomerular versus some tubular involvement. And, I think that can be a little bit tricky to assess with some of the standard laboratory tests that we have available. And so really kind of leads us to early diagnosis of primary glomerular disease, and treatment are really crucial to achieving some sort of a remission, whether that be a complete remission or even a partial remission. And so in one study, about 70% of cats with primary glomerular disease did have ICGN. And so, I think that leaves us with, 30% of the time, we can have other etiologies there. And so while the majority of the cases are likely going to be ICGN, there's definitely a chance that some of our therapeutics may not be effective for those that aren't in that category. And then, really mortality rates are fairly high with this disease process, with a variable prognosis. And, I think that's where I tend to really struggle with some of these cases. And so this study looked at their main goal was to characterize the clinicopathologic findings and prognostic indicators in cats with primary glomerular disease. They also wanted to evaluate the clinical variables and therapeutic interventions with short-term survival as defined by at 30 days versus long-term survival, and ultimately what is their response to treatment, and is it associated with survival? So patient data, they gathered some signalment of these patients, the clinical signs, whether that be PUPD, weight loss, edema. I put an asterisk on edema because I didn't feel like we had a great understanding of what was termed edema in this paper. Are we talking about pulmonary edema, interstitial edema? Are we talking about effusions? And so I think that's one area of clarification. I think also we always get these cats that are referred, and fluid overload is always a challenge. And so I think that are these patients presenting edematous, or is this more iatrogenic? And we'll kind of get into that a little bit later, but those were some questions that I had on the edema side. Looking at the clinical pathologic findings, there was some coag testing. Most patients had a UA and UPC and culture performed. Abdominal ultrasound, fine needle aspirates and cytology was performed in a number of patients, and then infectious disease testing as well. These treatments for these cats were divvied up into kind of IV fluids, immunosuppressants, antiproteinuric treatments, and antithrombotics. And so the medical records were kind of sifted through over a 14-year period through the Corrett School of Veterinary Medicine. And so, I think that our ability to diagnose these cases over the course of time has changed a little bit since 2009. And so, I think ultimately it's something that I think need to continue to look into based off of this being a retrospective, and there are going to be some inherent limitations, but overall I think there's some good information here. Cats and definitions. So they define primary glomerular disease with a UPC of greater than 2. And this needed to be persistent. And the goal was to exclude extrarenal causes. AKI and chronic kidney injury were defined with the IRIS guidelines. Hypoalbuminemia was defined as an albumin of less than 2.2 grams per deciliter. The azotemia was, if it was greater than 1.6, it was defined as azotemic. As far as treatment and remission and response, complete remission was found after their initial diagnosis if the cat had a UPC of less than or equal to 0.4. A partial response was a UPC of greater than 50% compared to the initial UPC. So survival was kind of stratified into short term, where these patients were discharged and alive at 30 days, and long term, based off of when the initial diagnosis was to their termination or death. I did like how the UPC, I put an asterisk there because they said that their records were reviewed by their nephrologist, which I think gives a lot of credibility to what we're all trying to do here. And so, I think just having kind of that standardization and, just I guess more of a keen eye at looking at some of these patients to, really try to tease out, is this truly primary glomerular, or do we have some extrarenal causes there? From a statistical analysis perspective, I thought it all looked pretty clean. I'm not huge into stats or have a stats background, but I thought that everything made pretty much sense. And so they did a Shapiro-Wilks test looking at the normally distributed data, and the non-normally distributed data were classified with a median and range. Students t-tests and Manuit-Liu were performed for survivors and non-survivors. The chi-squared and Fisher's exact tests were utilized for categorical variables between outcomes. They had some Kaplan-Meier data, log rank tests in comparison between groups, and a regression model, Cox regression model. between their continuous variables and long-term outcome. For all these tests, a p-value of less than 0.05 was considered significant. And so to kind of get into the results, so their first table, they had a total of 37 cats. They had 21 survivors, 16 non-survivors. The ages were not different between the two groups, but the majority of their cats were less than 5 years of age, at 76% of their population. About 68% survived a discharge. There were 4 cats that ended up not making it to the short-term survival, and so they were left with about a 57% short-term survival rate at the end of 30 days. And ultimately, looking at our Kaplan-Meier data, their median survival time for these cats was around 424 days. And looking at if you kind of remove some of the outliers here, their 95% confidence interval ranged from 0 to 1,098 days. And so, I think that these cats can do well, as shown in this data set. When we look at some of their clinical findings, the majority of these cats that were in the survival group had edema present at 62% versus 25% in the non-survivor group. Fever was not a significant variable, either was PD or weight loss. Going to some of their blood chemistry values, there was a difference in their CK values. The non-survivors had a higher CK. Whether they kind of discuss that in some of their discussion, whether there is some trauma related to blood draws, whether there's a kind of muscle breakdown association with that. I don't know, is there really going to be truly a true clinical significance in these patients? It is a small data set, and they only had 7 cats in that CK group that were tested. The AST was a little bit elevated in the non-survivors as well. Glucose a little bit lower in the non-survivors, but looking at renal values, the non-survivors were more azotemic. Their creatinine, the median was around 4 versus 1.9 in the survivor group. So this would suggest that the non-survivors were a bit more azotemic based off of their data set, and looks like there is a statistical significance between azotemia and whether they survived or did not survive. Looking at kind of infectious and concurrent diseases. So infectious diseases is something that I feel like we always screen for. 5 out of the 33 cats that were screened were FELV, FIV positive. There was 4 FIV and 1 FELV as the breakdown there. Leishmania was diagnosed in 2 out of 5 cats. Definitely with this part of the world, Leishmania is going to be more prevalent than, say, in the US, unless we get some transplants from across the pond, in which case, I think there is validity in testing for Leishmania in the US. Other infectious diseases that were screened for, mycoplasma, toxo, ehrlichiosis, feline coronavirus, Bartonella, and then Neospora were also tested for. None of those patients ended up testing positive, though. From their population, as far as concurrent diseases that were present, it seemed like pancreatitis was the most prevalent concurrent disease process in their cohort. There were about 4 cases that ended up having some underlying heart disease, and then other diseases, inflammatory diseases such as IMHA, stomatitis, dermatitis, cholecystitis, and hindlimb thrombosis were some other diseases that were reported. Um, they did find that there was no association between the presence of infectious diseases and survival on a short-term or long-term basis. And so I think that's a tough thing to with this cohort, none of these patients really tested positive for things like Bartonella, which, I've had a number of cases that have that are PLNs that are testing for Bartonella. So how does that play a role in that type of patient versus one that, in this paper, none of them had any sort of positivity with some of these other infectious diseases. So I do have some questions, and I think further studies are going to be warranted with that. When we look at treatment, immunosuppression was started in about 73%, 27 out of 37 cats. It was definitely more common among the short-term survivors in 18 out of 20 versus the non-survivors. And they did have an odds ratio of 7.3, which, I think would suggest that, when in doubt, starting immunosuppression is really going to be key to trying to ensure some both short-term and potentially long-term success in these cats. Antiproteinuric therapy was started in 25 out of 37 cats, about 68%. There's definitely more common antiproteinuric treatment was more common in short-term survivors, where 17 out of 20 versus 7 out of 16, and they had an odds ratio of 7.3 on that as well. And so, the antiproteinuric therapy, I think, is a tricky one, especially when you get cases that are not eating in hospital, and there are I think some concurrent GI signs related to AKI, and when to implement that therapy. We can kind of talk about that in a bit. And then antithrombotic treatment, there was no association between antithrombotics started and short-term outcome. So when we start talking about the different treatments, the immunosuppression, most patients, so 14 of the cats were on single agent, whether that was corticosteroids or mycophenolate alone. 13 had been on dual agent, so whether that be corticosteroids and mycophenolate or corticosteroids and chlorambucil. I think that's where there's not great evidence to suggest that one immunosuppressive is better than the other in some of these disease states, especially if we have some underlying inflammatory bowel disease or even small cell GI lymphoma, for example, where some of these cats may have been treated with chlorambucil as a result of that. The antiproteinuric therapy, benazepril was the primary ACE inhibitor in the majority of cases. Enalapril was also utilized, as well as telmisartan. 10 out of 25 cats achieved complete remission or partial remission after the start of antiproteinuric therapy. And so that's about looking at the survivors. With 21 survivors, about 50% did achieve a CR or a PR with their antiproteinuric therapy. And so, I think when we look at response to treatment in these cats, when we look at total, 36% did get a partial remission or a complete remission, and the median time to complete or partial was about 94 days, so about 3 months. And I guess that's where, looking at that number, are we getting a response from some of the recovery from some tubular damage as a result of that? And that kind of fits in a window where we are going to see some recovery there. And how much of these cats are truly responding from recovery versus responding because of their antiproteinuric therapy. And I don't think that this paper truly answered that question, but I think it's good data to or good questions to ask as we move forward with trying to get a better handle with this disease process. The partial response or complete response was associated with short-term survival. And so 65% of those cats that had a partial or complete response ended up having a benefit, and they found an odds ratio there of about 3.3, which was significant. When we look at these cats that actually had a good partial response or a complete response, the median survival time for those cats was almost 4,000 days with a plus or minus 840 days, versus those that did not have or did not achieve any sort of remission, whether that be complete or partial, had a median survival time of about 220 days with about a 65 plus or minus 65 days. So it does seem like the cats that are responding can do well. Those that aren't quite getting the type of remission that we're looking for, they're definitely going to stratify in the more guarded prognosis category, and I think that would be highlighted by their median survival time there. As we move on to the discussion, they note that edema is a common clinical sign and associated with a lower risk of mortality. Hypoalbuminemia was identified in about 77% of cats. And so, the question is, the cats that were hypoalbuminemic but weren't edematous, why are we seeing that type of patient profile where we are seeing the hypoalbuminemia, but not necessarily the edema? Is that going to be an indication of more progressed disease? Is it, were there some treatments that were performed prior to, these cats presenting to the hospital here? I think that was a little bit unclear, as far as the cats that were presenting with edema. Did they have any sort of previous treatments that were performed that could have been related to that? Markers of decreased kidney function, so an increase in creatinine, urea, phosphorus, was associated with an increased risk of mortality. I think that those that come in with more severe kidney dysfunction, I would say really kind of fit the bill of having a more guarded prognosis, and they did find an association with that. And then it seemed like in this paper that infectious PLN was relatively uncommon, where I think historically we run a lot of infectious disease testing on these cats, and sometimes we hit positives, which how much of that is directly related to their PLN. I take the Bartonella cases, for example, where, yep, they've had exposure, but, is this all related to this antigenic stimulation and immune complex deposition within the glomeruli? Is that going to be related to this infectious disease? And, I think we have to, I think until we get some more information on these cats, I assume that yes, that is the case. I don't know, and I'll kind of open it up to everybody as far as if you feel the same way. But if I don't have any other underlying reason or a concern there, then I do tend to, I guess, place the utilize the infectious diseases as a possibility for their PLN. Limitations with this study. I think the timing of treatments is always a big one. So when to start your ACE inhibitor or your ARB. I will say that personally, if I get a cat that has a PLN that's in the hospital that's not eating, and we're in a position where GI signs are my biggest concern, I typically am not starting them on an ACE inhibitor right away. It may be a week or two down the line once we kind of get their underlying disease under control as best we can. They talk about some different inflammatory disease states. I think one that I've come up against that is most challenging is the GI disease cases where, I can get their kidney disease under control, but their GI disease tends to be the limiting factor. And, getting them to respond and go into remission gets to be really challenging when I have to stop and start my ARB, or they're not tolerating medications, or they have GI stasis. And so, I think that I would say the last probably 2 or 3 cases of PLN in cats that I've had, they've had some significant GI disease that, really is playing a contributing factor to their ability to tolerate meds and effectively treat them, both from a short-term and long-term kind of perspective there. Kind of touch on this, the edema portion. I wasn't quite clear on, was this, pulmonary edema, interstitial edema? Are we talking about effusions here? And so was this more iatrogenic related? Was this related to their primary disease? And I recognize that it's challenging to do in a retrospective, but, I would say that most of the cases that I get do come in edematous, but it's generally because there is a portion of these cats that are already iatrogenically fluid overloaded. And so is that related to their primary disease to start with? And, was this a, iatrogenically induced edema versus is this truly related to their underlying disease process? They did mention in this study that some of their treatments, a number of these patients received some starches. One cat did receive some human serum albumin, which, I think can be a little bit of a confounding variable with are concerned with some tubular damage with the starches. The HSA, is that a contributing factor to potentially exacerbating an immune complex deposition? I think that's hard to prove, and especially in a retrospective nature. But I do think that some of that is a little bit confounding, given that, if we're looking at the kidneys and, use of starches and without biopsies, then, I think it can be a little bit challenging from especially the non-survivor group, if a number of them were in that category, how does that play a role? And then I didn't see any mention of blood pressures in there, and I think always I'm always curious, especially reading a kidney paper. Do we have blood pressure under control? And presumably so, but there just wasn't any mention of systemic blood pressures in these cats. I think another limitation, and probably the biggest limitation, is renal biopsies. And I think that we can all agree that the renal biopsy is going to be the gold standard to definitively diagnose these patients, whether we're dealing with a true ICGN or a non-ICGN process related to their primary glomerular ICGN. And then, I think that as we move forward and trying to understand these patients a little bit further, urine STS page is something that we utilize a lot. I think it would be interesting. I get a number of cases where you get their initial SDS page and it shows some high molecular weight banding that is lost in the urine. You also get a pretty extensive tubular band as well. And so is there actually some merit in reevaluating these patients down the line when we suspect that they have some remission? And so I think that is something that I think there is a significant tubular component to these cats, especially if we diagnose them during an acute event. And so how much of that is going to be, true resolution based off of their antiproteinuric therapy, or are we seeing the recovery as a combination of both? And, I don't think that we have, great data on that at this point, but hopefully soon to come. So, in conclusion, PLN does carry a guarded prognosis. Cats that do receive remission, they can have a good long-term prognosis. I think that the key there is getting some sort of remission. And so, the cats with acute disease, hypoalbuminemia, edema, and rather than azotemia, so those that come in azotemic, are going to be in the more guarded category, but those that are, really just dealing with the hypoalbuminemia, the edema, they are more likely to respond to treatment and are likely to have a much better survival time. And so I thought this case was, or this paper was, like I said, quite timely for some of the cats that we've been dealing with most recently. I think overall, I do find these cats to be very challenging. And, kind of back to Luna, we ended up we didn't end up getting a biopsy on her. I think that's always the challenge to recommend biopsy. I'm not super confident in our skills to do it percutaneously right now. And, I think it's always a challenge to recommend a surgical biopsy in, a cat that's, having waxing and waning signs. This cat, we ended up starting on some steroids, mycophenolate, some telmisartan, some clopidogrel, and then phosphine or aluminum hydroxide. This cat really developed some significant hypomotility of its gut. And we did do a GI panel, which showed that this cat's cobalamin was greater than 1,000, but overall, nothing that would suggest true malabsorptive disease. This cat also had a persistent lymphocytosis, which on flow cytometry showed just a reactive population. We never got this cat into remission as defined by this paper. And, it's, I think it was quite challenging as this cat was on and off of telmisartan, on and off of mycophenolate, and it completely stopped mycophenolate and honestly was just on a single agent. This cat ended up living for about 14 months or hit about 420 days. She did have an E-tube for the rest of her life, and that was the only way that I could get control of this cat's GI signs. And I think it just kind of poses a really challenging case where when you're dealing with GI signs and the need for antiproteinuric therapy, I find that really challenging to, pick and choose our battles there. What do we try to address the GI issues and sacrifice the kidney versus, the other way around? And, for this cat, we ended up stopping the telmisartan, stopping the mycophenolate, and, really maintain the cat on a single agent. And the cat, I would say, clinically did okay. This cat was in the hospital pretty frequently, and ultimately over the 14-month time frame was probably in and out of the hospital about 15 times. So I think they're really challenging cases to manage if we're not getting that initial response. And so I think overall I do struggle with these cases, especially the ones that come in azotemic. And we do have some pretty dedicated owners, but ultimately this cat did succumb to its GI disease, and ultimately the kidneys I felt actually were pretty well controlled from a proteinuria standpoint. So that's all I've got for this paper. I thought it was quite a timely paper, like I said. I think we need more biopsies. I think everybody would agree with that. And I think overall, I find these cases to be really fascinating, frustrating at times. But I just want to maybe open it up to people on the call here, and what is your experience in some of these cases? Given that there seems to be a wide range of possibilities from an etiology standpoint. And I guess the true question that I have is the Bartonella cat. Are we treating it for Bartonella? And is this the etiology? I think that I'm quite confused on that. When I do have these cases that we're treating here. Let's look at this chat too, if we can. Uh, Dr. Hellcamp says, very timely. Many of these questions are ones that Dr. Quimby is trying to gain insight on. She has increased her case submission of urine SCS page to me and is trying to encourage more biopsies. I was hoping Dr. Quimby would attend.
Yes, hey, can you actually make that? Sorry, we've got two. We can turn the whole thing down. Sorry about that. We have the feedback from a second microphone in here. Yes, unfortunately, she actually messaged me as she was unable to attend. She has been seeing a number of these cases coming through and texts me very frequently and then submits, and she is frequently doing follow-up SDS page. I have some cases with 8-10 SDS page that we're following on from multiple cases. Exactly what you pointed out is what we're currently lacking, which is sufficient biopsies in these cases, which obviously there are very real reasons why we don't necessarily biopsy them, but we have significantly fewer than we do in proteinuric dogs or in PLN dogs. And so right now I'm still facing a bit of a challenge of the correlation. I see cases where I think this SDS page, these banding patterns are correlating really well with the biopsies. But then so many of them, I don't get that actual tissue information. And so unfortunately, I'm still a little bit in the dark there. But we are continuing to work on this. One thing that we have seen a correlation with, or rather I should say Dr. Quimby has, and we're working on exploring this in terms of the potential etiology or potential trigger, are cats with pododermatitis. So she's had a number of cats that have come through that have pretty significant protein losing nephropathy, and at some point in the exam they flip them over and look at their paws and, oh, you have podo, and it is not well controlled. And so that's something that we're also looking into as well.
I remember a couple of those cases. Um, I think what was quite fascinating, the last renal pathologic round was the case that JD presented, the amyloid cat, which, you know, had it sounded like had some stomatitis to some degree, some chronic inflammation, and ultimately with the biopsy, you know, all of us are assuming that it's going to be ICGN, but it came back as amyloid. And so, you know, how many of these cats actually have some degree of amyloid deposition, you know, rather than it being, you know, a true ICGN. I know that some of the papers are, you know, suggesting ICGN in the majority of these cases, but, you know, still kind of is a question of mine is, you know, that 30% or so that are not ICGN, is amyloid, you know, going to be a big player as well? So I don't know. I think there's a lot of work that we need to do with these cats. I'm going to be doing a lot more biopsies, I think, in these cats, and you know, just to try to get more information, especially, you know, in real time here, because, you know, I do find these cases really frustrating and challenging, and, you know, ultimately I do think that some of these cats with some of their underlying etiologies, whether that be infectious or, you know, GI disease or whatnot, they really are challenging from, you know, I can get control of their kidney disease, their creatinine improves, their UPC improves, but then we have flare-ups. And so I think overall it's, I don't know. I struggle with them, and you know, it's something that I think we need a little bit more information on from the biopsy perspective. How does that impact the treatment that you recommend if we know that likelihood is probably ICU or amyloid? I mean,
Maybe my question is confusing. Basically, we've seen the same thing, and it's like, oh, I'm totally expecting this one to be an ICGN. And if they do biopsy eventually and it does turn out to be amyloid, what would you do differently given, and this is coming from a clinical pathologist who doesn't treat, so.
Yeah, I guess, and I don't know if the case that JD was presenting, if he ended up putting that cat on steroids for some chronic inflammation. I think I can't remember that off the top of my head, but you know, I think that if we have some amyloid deposition and we are identifying a chronic inflammatory state, then I don't know if that necessarily changes. I think it probably changes prognosis, and you know, I think that that's what I would be worried about is if we can't get control of the underlying inflammation, and you know, these cats are still depositing a bunch of amyloid, then, you know, I wouldn't expect this patient to respond as well as, say, you know, the cats like in this paper, for example. But you know, I think it's a good question, and I think it's one that, you know, we probably just need a a cohort of cats with amyloid to, really kind of follow them out and kind of extrapolate what their treatments were and, ultimately how well they've done with, depending on what types of treatments were performed and whether that's corticosteroids or not.
And I'm not trying to dominate the question pool here, so I apologize, and I'll be quiet here in a second. But if you have an owner who can't biopsy, and let's say you do SDS page and you get back those high bands, and you know that the likelihood is either ICGN or amyloid, regardless, but they're not going to be able to biopsy, do you still just go ahead and say, we're going to try immunosuppressive? And that's what Quimby recommended, or she and I have been talking about. And then it's like, well, what else can we really do? And then again, it's a response to treatment is the presumption, realizing that there's a lot more we don't know yet.
Yeah, and I mean, I think that's the challenging part is, I get your report and, I see those high molecular weight bands. I'm like, well, it's probably going to be ICGN, but it could be amyloid. And, I don't think it necessarily changes the way that I treat the cat. I think it's more of, okay, are some of these cats actually not responding as well because they have amyloid deposition and they have is their prognosis more guarded? That is as a result of that versus the ICGN. In dogs, I feel like if you catch the ICGN early and they've got good tubular function, then these patients have a good prognosis. And ultimately, can we see that in cats? I would say that this paper could suggest that. I think we are missing the biopsy component, but can we see some of the same favorable outcomes in cats that we can see in dogs if we do catch it early? And I think that's still the question. And the lack of data that we have from a biopsy perspective, evaluating, yeah, that's where the biopsy to me is really important. Is, yeah, not only can we look at the glomeruli, but then we can also look at the tubular interstitium. How much fibrosis is present? Is there calcification? That's going to lead to me telling an owner, hey, you know what? I don't think that this is going to go very well because your cat's full of fibrosis versus, one that we catch early and we don't see some of those secondary changes from chronic proteinuria.
Yeah, exactly. Thank you.
Any other questions, comments, concerns?
I thought this was a really nice discussion for sure. And I think one of the things that I really appreciate you sharing too, like with the clinical correlation, is the challenges in um, medicating these cats, and I would argue dogs too, but of like, putting them on antiproteinurics and um, whether they're azotemic in that situation too, or have GI signs. And I, I thought that was interesting. I think that in this study, looking at the kind of better, shorter outcomes with those antiproteinurics is always or slightly kind of improved. When I read that, it like made me cringe a little bit because I'm always hesitant to start those when they don't feel well. So I appreciated kind of your side comment on that.
Yeah, I mean, I truly think that it depends on how they present and, what grade of AKI they come in at. I'm not starting an ARB or an ACE inhibitor in a cat with a creatinine of 7. Like, I don't know many of us that would. But, I think that most of these patients that I have, and they are in that camp, I mean, they're getting an E-tube and, I gotta start treating, and immunosuppressing them to start, and try to get some control of inflammation there. I think overall it's I think I find it very challenging to, especially if the cat's not eating. I don't know if it would be possible to, effectively treat these cases without an E-tube, honestly. And quite frankly, that cat Luna, like, she wouldn't have lived as long as she did without the E-tube. All right. Well, thanks all for attending. Hocam says cats should be born with E-tubes. It's their insurance policy. That's what I tell owners. All right. Have a great one. Take care.